So thank you again to all the panelists, and just sincere thanks for being willing to come and participate in this. It's a good opportunity. So at this point, we can really go back to your list of questions that I hope you've been making over the last 15 minutes, and start to have some dialogue. Maybe I'll start that off because it feels like all of you referred to some of the challenges associated with undertaking, whether it's international accreditation or One Health accreditation. And so just if you had to name one thing that was the hardest and how you've dealt with it, maybe that would be a reasonable place to start, and then we'll turn to the audience.
So one of the things that I think I personally have found a challenge within the United Kingdom, I was part of the International Accreditors Working Group, was this concept of the threat of mutual recognition, right? Now, the minute you raise mutual recognition, people head for the corners or the door, one of the two. And the reality is what we've been talking about, I think in a very constructive way more recently, has been harmonization. And for me, I don't know if any of you are in choirs or play instruments, but harmonization means that you're singing the same kind of song, but you can be playing different parts. They just sound good together. And I think the more we can get the harmonization element as a starting point, then the mutual recognition might come, it might not. It doesn't really matter, but the harmonization of standards and the recognition of standards at that level is probably the most important, but probably the most difficult thing to get through in the first instance, because people see the two as being synonymous.
Yeah, I would echo that. And I think some of those early meetings, and even the first International Accreditors Working Group meeting in the fall of 2007, had some contentious parts to it. There was a lot of struggling for positioning, I guess, and maybe less active listening on some people's parts. But over time, and I think that's what it takes, is time of people working together and understanding where everybody's coming from and understanding the similarities and the differences and having respect for everybody's similarities and differences. I like that idea of harmonization, although within the Council on Education, that still is a scary word. I don't know why, but it is. but I think that's what it's working toward, is looking at those commonalities in the standards to be able to really work together and learn from one another. And I think it's done a great deal of good.
Thank you, Deborah, and I agree with the two. But what I found in our region mainly is the word protection. Governments wanting to protect their own. This is ours. These are our people. These are our standards. And protection within the universities. Universities want to vary. Universities want to attract different applicants. Universities have different professors. They want to protect themselves. This is our own. Breaking that barrier is not easy. And lastly, the professionals, even within the universities, they want to protect themselves. They do not want to open up and say, we can do things together. We want to do our own research, want to do our own things. And I will tell you, I have an example of a cardiologist who said, you are talking nonsense. I've been a cardiologist for all this time. Don't tell me about veterinary medicine, nursing. I'm a cardiologist. And we were on the same panel in one part of this country. And those three groups, once we break them to talk, to listen to each other, I think a lot can be done. Thank you.
Thank you. Yeah, Beth.
So there's one other challenge that that working for the professional association that comes into play is the different levels of desire or understanding of globalization within the profession, and the idea of looking outside our borders as a tool for growth as opposed to closing our borders down and protecting our own. And I think that can be a challenge, and a challenge on how to start that dialogue within our own profession, the U.S. veterinary profession, so that we are all on this, at least somewhat the same page, and understanding what the idea is about global outreach versus what it isn't. And that can just be a struggle. I'm not sure if you find that in the UK at all, or across Europe or in Africa, but there seems to be somewhat of a protectionist element. So
I think we've certainly seen that played out in this country, sort of like the political elections. But yeah, I think the other point is that we've all seen probably the world map with many, many arcing lines that represent either airline flights or just how quickly things now move around the globe. And so for veterinarians who think about diseases that move from animals to humans and how quickly, and humans to humans, how quickly that can happen now, it just becomes an imperative that we work, it seems, across geographic regions. So yes.
On that theme of globalization and the facilitating and barrier related to this concept of globalization, it seems to me the issue of environmental health, which is part of this One Health thing, it is another critical potential facilitator on the one hand and barrier on the other hand, depending if you believe or don't believe in climate change and related issues. So I wonder to what degree you've used that in a positive sense and to what degree you've seen it used in a negative sense in trying to bring people and countries together.
Thank you. I think one of the things that we consider very serious and key and center is environmental health, because environmental health brings actually the different disciplines together. The veterinarians, the human, and the nurses and social scientists. So to say, when we are looking at programs to strongly or to make strong on One Health, environmental health has been considered. And those universities that did not have environmental health, we have encouraged them to establish those training programs. And I must tell the audience that some of the universities that are part of the network did not have even the basic. But now we have encouraged them through the funding from USAID and our partners to establish these courses. And then they didn't have the professionals who teach this. Because we have this database, we share them with the people that we have to train their own countries. So yes, environmental health has been key and it is being addressed by your share.
Could I answer the question with another question, first of all? So veterinarians, keep your hands down. So those of you in the audience who are participants who are not veterinarians, what was the first disease that was eradicated from the planet? Hands up if you know the answer. Smallpox, right? So nobody put their hand up, so nobody knew the answer. So I don't hold out a lot of hope for question 2, which is, what was the second disease that was eradicated from the planet? Rinderpest, right? It's a cattle plague. Very few people know that. So to extend that last question, so we talked about environmental scientists, but the FAO, Food and Agriculture Organization of the United Nations, has a wonderful paradigm within the One Health concept where they talk about the 3 levels. So at each of these levels, there's the host, there's the agent, and there's the environment. So that beautiful Venn diagram that we all knew and loved when we were undergrads. They talk about the 3 levels. They talk about the technical level, which is, do we have the vaccines? And then they talk about the societal level, so the behavioral level. Do we maintain closed herds? Do we have safe sex? What is it we do? And then the 3rd level is there intergovernmental or legislative support to put in place that program? And that, if you bring those 3 together, and I have a beautiful dynamic PowerPoint slide that took me hours to make, and I'd really love to have shown it to you today. And I've shown you it twice. It took me so long to make it. But bringing those 3 levels together, the technical level, the behavioral, social level, and the institutional level is what ultimately delivers a One Health answer. And you can think of the different places that that's happened, whether it's human papillomavirus vaccination for teenage girls. That's a One Health solution, absolutely. Rabies, that's a One Health solution that we're not delivering on. We've got all the bits and pieces in place. So absolutely, we've got to bring those together, but we've got to bring it together in an appropriate framework that addresses those three levels. That's the FAO's aquaculture program has that quite nice paradigm.
And I would just add Stuart's comment about rinderpest. You think of cattle plague, rinderpest, it's a cattle disease, but then think about the consequences of massive numbers of cattle dying. It's decreased protein in the diet, it's decreased livelihoods, it's women and children now having to do more work because the family doesn't have resources anymore. So there's a tremendous ripple that's not usually very pretty associated with the consequences of not paying attention to One Health.
I was thinking about environment in a different way than the what Malcolm was talking about, and part of it is my Kansas roots. And so I just think about it today in terms of what we put on our crops, what then ends up in our chickens and our beef and our pork and eggs and all of the food that we eat, and some of the challenges that we're having today with what people are discovering with allergies, with all other kinds of problems, because frequently we're not aware of what it was that might have been in the crop that was raised and the sprays that have been used to get rid of the weeds. And it's just been interesting to me, going back to my roots, to think about all of those changes and the connection between environment today and what we think about in healthy lifestyle and the issues we have with ADHD and autism that have changed, that some people relate back to the environment. So I think there are ways to look at that healthy lifestyle issue that we were talking about in health and wellness and the One Health, just from the standpoint of looking at our whole food sources here in the U.S.
Thank you. I think that's a good observation. I would add to that antimicrobial resistance. That's become a very large topic of conversation. I want to switch gears for just a minute and ask, because I know these panelists have had very specific experience of how do you, in fact, go from the idea of One Health to putting that into a functioning way in an educational curriculum and then looking at the outcomes of that. And so William, I'm thinking of OSEA from the point of view of, there was a mapping, there was a gap analysis, there was, so if you could just give us just a little thumbnail of how you started out to approach these topics on a very practical level.
Thank you, Deborah. And I must say it was not easy, as I said earlier. And then we said, if we sit and wait, history will judge us. So when we met as deans, this is a consortium that the leaders are deans. So when you cease to be a dean, you actually become one of the advisors. So we asked ourselves, what do we teach in our universities? What is available? And whatever that is available, can you actually bring it and we assess it? So we had nominations from schools, from different schools across the countries. And I must tell you, other countries are now applying that they want to become part of the network. And we are telling them you can be part of the network with your own funding, because we do not have the funding to go over. So when they brought them together, then we had people who are professionals, not necessarily part of the network, but who are known to be specialists. And we say, look at this curricula. And then we said, so what happens, what is common, what is in one area and what is not there? Then we said, what are those skills and competencies that we want as One Health that should go and become common in all of them? So we got specialists, curriculum development specialists, and we told them what the skills and competencies we would want to be put in those curricula. So those people put them in, or they developed them, and then we asked these deans to take them back to their universities so that the faculty and the schools would discuss and accept them. Because what we discuss and put as or share must be acceptable, 1, by the faculty, 2, by the universities, 3, by their own countries, and 4, by their regulatory bodies. Because, for example, we have the East African body, then we have the body for each country. All those bodies must accept. So it has been a process, and the process is not yet complete, because we have had those that are coming in new and fresh. But I believe, Deborah, that soon we'll have the process complete. And what we've done is that those curricula that we have finished and completed and are ready to go, we encourage those that are not members to use them. These are public documents that we give out, so that across the board, across the region, we train. If somebody moves from Kenya, you can go to another country, say South Africa and so on, but have those competencies and they're acceptable. Then the last thing was, if we put them there, would we have, if somebody was getting his degree and is going to practice, would he be acceptable? Would he be comparable to somebody who finished before? So we said we must develop programs for those who are in service. How do we look at the people who are already in service and try to bring them on board so that they understand? So we developed short courses and continued medical education and other programs. And we have gone ahead to give them to the veterinarians in service and other professionals. So we are not looking at those whom we are training now. We are saying they are going to meet those who are already trained and they will not be acceptable. And because these bodies for accreditation are looking at this now, how do they look at those who are already in training? Thank you.
And so I think a big piece of that is outcomes assessment. So Stuart, Beth, would you guys like to comment on where outcomes assessment, Beth, you sort of laid the groundwork, but how that's evolved across nations and One Health? Because that's hard even if you're just one discipline and, you know, one accreditor.
Yeah, I'm not sure I can address specifically the One Health aspects of it, but I do know that in the gosh, it's almost been 2 decades now since the council put in a separate outcomes assessment. There's been so much dialogue between the schools with the other accreditors. The fact that the Association of American Veterinary Medical Colleges have schools not only in North America, but also around the world, coming together and talking about what does it mean to measure outcomes? What are we looking at? How do we do that? What does that mean? And just all kinds of different ideas, the clinical competencies. I mean, it's easy to say, well, a licensing exam is one outcomes assessment, and certainly that's true, but there's so many others that are there and that you can use throughout the educational process. So for me, looking on it as a staff person to an accrediting body, working at getting even a basic understanding of what outcomes assessment is, and people coming into that with varying degrees of desire to deal with it at all initially. There was a lot of pushback to now kind of embracing it and seeing how it can be used to actually in some ways drive innovation. And so the questions that came up yesterday between driving innovation or hindering innovation, I was torn on that because I can see it really driving innovation to look at how you might assess outcomes and then tie that back in. And so I think the same would hold true with some of the things that William talked about with the One Health curriculum that they're developing and that is in process. It's the same type of thing, is looking at what is the outcome you want. And that can be a hard point to get to come to some agreement on. You know, for the Council on Education, it's an entry-level veterinarian for practice in the US and Canada. And that's going to look very different than a specialist. And many people on the council are specialists, and so they have to kind of take that hat off. And practitioners who employ the new graduates sometimes forget what it was like to be a new graduate. So they seem to remember being able to jump out and make a lot of profit for their boss the first day out. And so just a better understanding of what it is that we're trying to produce, and how the measurement. I think there's a lot of really cool stuff being done at the veterinary schools on outcomes assessment.
So two things. The first one is to recognize, I think, and it's great to be able to do it on American soil, the work that AVMA and COE have done on outcomes assessment, because we've been talking about it for a long time. And it's a bit like One Health. What does it actually mean? What does outcomes assessment mean? And it means different things to different people. And I think most recently, this idea of embedding the outcomes assessment in that sort of virtuous circle, the feedback loop of how does that outcome then change what you have been doing, is absolutely critical. And that's the thing that I think is most exciting about the most recent standard that's been published. So the fact that we haven't really understood entirely or had a common understanding of what outcomes assessment actually means, I think, has been a bit of an issue. And put beside that, the fact that we don't all have the same common understanding of what One Health means you've got actually a bit of a challenge there. But the idea that on a One Health basis, and if you take the Emperor's New Clothes paradigm seriously, then you recognize that there are people out there who've been One Health practitioners for an awful long time. How do we formalize that? Are there careers out there? Are there jobs out there? I'm not sure that we're quite at this point of saying we are able to develop a complete set of outcomes assessment for the One Health professional, because I think it does mean different things in different contexts. And that's the debate that we're having. And that's really the accreditation challenge, because we're not quite there yet, in my view. Although I have to say that I think some people are an awful lot further down the road than others, and I congratulate William and his colleagues on that.
So I would invite the audience. Do you have thoughts on that? Do you see ways that you can help us get there, or is this misguided?
This question is for Stuart, because he and I share the same country. But I wonder if in your deliberations you've thought about how the knowledge and skills framework that was introduced to the health service might be a bridge to have some of this further discussion, because when it was introduced back in the 80s, it did enable anyone that was working in the health service to be within a single common competency framework. And basically there's a core set of competencies which every single practitioner, whether you're a priest or whether you're an engineer or whether you're a doctor, had to have in their job description, plus what they called subject-specific competencies. And I'm just wondering if that's featured in any of the discussions that you've had in your deliberations, Stuart.
Short of saying that when I was in practice, I think a lot of people did end up praying for their animals. So maybe that's one example. But I haven't been in practice for a long time. I don't think that has been the case. There's been last year I was president of the Royal College of Veterinary Surgeons, the regulating body of the profession in the UK, and in trying to modernise some of the aspects that we do and to become really a first-rate regulator. We have looked at a number of different models. Whether that has yet reached, and I don't think it has the level of educational accreditation, which I guess is in primary qualifications, I don't think that would be the case, but it certainly be an important one to embrace, as we have now taken into our fold the allied professions rather than paraprofessionals. So we now regulate veterinary nursing, for example, and we have the ability under our new Royal Charter to regulate other professions should they wish to be regulated by us. So I think when that happens, then there's a really good opportunity for that framework to become much more relevant than it is at the moment. But thank you for that.
So what do you think about One Health? Is this just wildly ambitious and bad idea, or do you think it's a good idea? What do you see as the potential benefits in your own areas?
So unfortunately, being in my centric medical lab, I'm thinking of the triple aim, where the health of populations become a primary driver. I don't see how you can think about health and wellness and not think about One Health, given everything that's happened. I mean, the effects of the environmental changes, I can't help but think about what's happening right now with Zika, as well as the, tragedy of Ebola, which you talk about a One Health issue that happened the past couple of years. So I think they're very tightly connected. One of the questions I had for you is, I appreciate Winnie's, but what would your recommendations be, particularly on the veterinary side, for us working more in the, quote, health professions or the medical professions with humans, so to speak? How do we better engage you, through this One Health initiative? What do you have recommendations for us?
You being the MD in the group, and
Thank you. And in my opening statement was, I think I said, veterinarians, I congratulate you, those who are in veterinarians, for practicing One Health even before you knew or you intended to do it. So how do you engage us? I think, how do you engage the medics and other people? I think it is all collaboration. There must be some desire to address an issue. If, for example, you look at, you talked about Zika, you talked about Ebola. What did we do? I'll give an example for Ebola. When there was Ebola in West Africa, hardly did we know that they didn't have even the professionals. We didn't know. We thought they had professionals and they were fighting the disease. So when we offered to go there and we sent our people found nobody. The very few people who were there and who were trained actually ran away, and they even got visas and came to this country, to America, instead of saving their own people. But whom did we send there? We sent there this multidisciplinary team: social scientists, environmental health people, medics, and vets, because the experience we have in Uganda, and I think we are on record, Uganda has had this, and maybe that's why we lead One Health as a challenge. We have had so many epidemics of different diseases. Ebola, we have had it, I think, Professor Nsanga, is it about 5 times? The last time it was there, it only affected 1 person, and we were able to contain it. So we had this experience. But the people in Uganda that have been trained actually are not only medics and vets, we have included the others. But we had the convening space that Professor Sewankamba and others in the Ministry of Health were able to talk and say, we are going to die when these things are available. So the vets and whoever all came together. So I would encourage that the associations are there. The Association for Medical People and the veterinary associations are there. These are good groups to start from. For example, next week we are holding all the professionals that I've talked about. We are in the World Veterinary Week. And we have said at the end of the week, on Saturday, we are going to have exhibitors. And somebody talked about innovation. What we have done to my colleague who is looking at those drugs and what chemicals that are being used in the crops, we have engaged our students and faculty to have innovations that actually address some of these issues. For example, people who are growing a lot of maize or corn, as you call it, soon they will no longer need chemicals to spray for their crops, because innovators in our universities have come up with this weed which doesn't need a spray, and it's grown along the middle lines, and it attracts or stops these weevils and whatever those organisms from growing in, and even stops the other pest weeds. So I think we need to use what is available so that we come together with a common vision. To come together because you are in your own silo, somebody is in his own silo, but you know what is the problem. So these known bodies should come together. Lastly, I think the accreditation or the bodies that do accreditation are doing a great job. I must thank them. But they also need to sit and come back and say, this is where we were, this is where we are going. Those which are in Europe, like in UK, come together and they say, is this how we want to continue? No, because the world has changed. You hear of Zika on this side, but Zika will soon be in Europe, Zika will soon be in Asia. We must find it there where it is and stop it from there. I'll tell you, our One Health program working with the Resilient Africa, we said medics and other people go to treat Ebola. They also get sick and they die. So how do we protect them? We won a grant to design the new generation tent for isolation and treatment of Ebola, which we finished and it was tested and will be launched in West Africa in about 3 weeks, whereby you'll have people go in and be like a normal hospital so that you don't go in to treat people and then you get out with the disease. You do not isolate all patients and then you have the stress and the psychological whatever when their relatives don't go in. This tent has been developed by our School of Public Health and the people on the tent, developing the tent, you cannot imagine. Every professional has been brought on board to help and design this. Thank you, Deborah.
So I think my answer, you might say, well, you would say that because I'm interested in it's my scientific endeavor currently. That is, if you're going to make something happen, you have to pick some low-hanging fruit. And the lowest hanging fruit, in my view, on the One Health agenda is antimicrobial resistance. If we can't get our act together on that together, we may as well forget about the whole thing, to be quite honest. Because it does involve environmentalists, it does involve technologists, it does involve medics, it does involve veterinarians, it does involve farmers, it involves everybody. And I think if there could be, and I'm not saying that there aren't other more very important diseases to be addressed, but I think if we define some specific projects that are truly multinational, and I think this one is starting to emerge, no, it is emerging, definitely, as a task force that has to be international, and it has to be, as I say, not transdisciplinary, not just multi or interdisciplinarity.
Any other thoughts on that? I'm going to bring us back to a comment that I made in the introduction, which was that we need a new breed of student who sort of doesn't think about themselves as a specialty, but rather across these specialties. So one of the really wonderful parts of One Health, and it's played out in this country, it's certainly part of OSEA, I think it's part of UK and Europe, are One Health clubs. And these are clubs at the student level that have medical students, veterinary students, nurses, public health. And, you know, just like students now relate to a digital display somewhat differently than I do, they also are not troubled by the lack of lines if they start to think about it early. I think the longer they are in our systems, the more they get in the same boxes that we're in. But those One Health clubs have been really quite fun to watch. And so I would just invite the panelists, if you've had experiences with watching the students kind of embrace One Health, that maybe we have a comment on that.
And very, very briefly, and I think both the leadership in the schools and probably the accreditors have to take the blame for this. If you turn the clock back 50 years ago, medical, veterinary, dental students were all taught together in the early years, and the accreditor said that wasn't a great idea, so we stopped doing it. There you are.
I think as a surprise, I will not answer this. I have my project manager who is here. She's directly responsible for this. I will take her by surprise and ask her, can you please answer this, because you deal with these students across the countries. She's Irene. Irene, I'm sorry for taking you by surprise.
Yes, this is a surprise, but yes, I'll comment on that. In the OSEA network, every country has what we call One Health students clubs, and these are multidisciplinary. The clubs are constituted of veterinary students, medical students, agriculture students, even engineering students. So what they do, they come up every year, they have their own work plan, and they give us the work plan, which as OSEA we fund. So they have activities ranging from doing sensitization in schools, going to communities, and even going to slaughterhouses. So the activities, even going on air, on radios, and talking about One Health. So this has helped for students. We have not had a problem with that. With the silos in students, that has not been registered in any of the countries. All our students have embraced this And I don't know why it's been difficult for staff, but for students, they've embraced it with one heart. So that is the experience we have.
I would add that we have engaged these students in outbreak investigations. So they're trained in surveillance, outbreak investigations, and how to manage the communities. Now, she says she doesn't know what is wrong with the staff. I said it. We think that we are professionals and we don't want to go down and say, how do I work with so and so? But we are getting there.
And then we have a question here.
So some of the schools, the veterinary schools in the U.S., and more of them, if they're co-located with medical schools or other health professional schools, they can incorporate some, particularly in problem-based learning type of case scenarios, they can incorporate cases that will really are One Health. So I don't know if anybody's noticed, but it seems like cases of rabies in domestic animals and human exposure to rabies is on the rise in this country for whatever reason. And so rabies is a true One Health issue. And so looking at real studies and bringing students from the various professions to address those challenges and see what they can come up with as a team. And that is happening at more and more universities. That's, I think, one way of the question that came up is how can the medical profession engage? It is easier with, I think, just the younger students, just because they're not so set in their ways. We tend to get set in our ways, and this is our box, and no one can touch it, And so I think relationship building is really, really important.
Thank you. Yes.
Susan Scrimshaw, Forum co-chair, and we've talked in the last couple days about something that I think now need to bring into this discussion, and that's the issue of policy. We have talked in health professions education about the extent to which our students and our health professionals understand the critical importance of policy and how to be engaged. And I think that a couple of the examples presented here are typical. We eradicated smallpox. We have the means to eradicate polio, but we have not fully eradicated polio for really political and international war and cultural and other reasons. Zika, in this country, Congress is refusing to appropriate the funds needed to do the preventative work for Zika. So I think as we look at this very global approach, which I have to say is, as a public health person and as an anthropologist, I fully embrace and applaud, how do we also include the ability to convince our policymakers that these are critical things, because that ultimately affects the outcomes that we're all working towards and that we're holding people accountable to when we're looking at accreditation.
Great question. Yes, William.
Thank you very much. And I'm not surprised that the Congress is refusing. I'm not. And I'll say this, and unless you get a case, some cases in the US, Congress won't move. But I think if we are talking about global, international, I think disease is bad for us wherever we are. We need to fight it with as many professionals as possible coming in. Policymakers, unfortunately, do not behave the way we do. But on the other hand, some of the policymakers have been part of us. And when they go to policy, I already said they get overwhelmed by what they find there. They forget that where they came from, problems still exist. So what are we doing in OSHA to make policymakers be part of what we believe? We formed what we call the country coordinating committees. Country coordinating committees were not easy to form because we asked governments to nominate. And in some countries that I will not mention here, people in health said, we must be on this committee if we chair. And others said, if I'm a vet and I'm not sharing, we are talking about animal diseases and so on, I'm not part of this committee. So we had to do some sensitization, and I remember traveling with some colleagues to some countries, talking to their ministers and their directors, saying, look, you are a minister, but it has no harm if you don't chair, or your person doesn't chair. So we've been able to have these country coordinating committees, and whatever they discuss on One Health, they take it to the regional body, the East African community, the African Union. We have a session that we are going to participate in as One Health, as a share that we are going to present. We've been asked to present to the presidents in the African Union. Why do we believe that it works? Because we have convinced the ministers and the other bodies, agriculture and so on. So they say, okay, we are convinced, but you also come and convince our leaders. So we'll do that. We have had sessions to convince and talk to policymakers at the regional level, the East African community. And myself and other colleagues who have been there, and they have bought it. It's now on the agenda. It's now on the agenda for East Africa. It's now on the agenda for West Africa. So we are looking to get the other people to buy in. Lastly, why do policymakers try to resist? They resist because they think it has implications with financing. And what we are telling them is that whether you accept it or not, the finances remain the same, you must spend the same. However, if you accept it and embrace it, there are chances that you reduce your expenditures. Your budgets reduce. If, for example, I know there's a team that came from CDC and others, they came to Uganda to investigate Zika. When they heard about Zika here, they came, they said, Zika came from Uganda, so they came to Uganda. They did blood tests, they screened people, they took blood from animals, in those monkeys and so on. They have found no trace. What does it mean? The question I had when I met the team was, where do you think Zika has been since the time it was found here? So we must trace it the way. But what did I notice? This group that came were only medics and vets, nothing else. And I talked to them about the other groups being involved. So I agree we need to do more, but who is going to do more for us? These bodies that do accreditation. Invite policymakers. I wish in this meeting, since yesterday, there were policymakers here to listen. I wish we have members from the public who are not necessarily professionals, but come and participate. Because the team that sat here, when they talked about who is the person, who are the people, these are the people. We should stop talking to ourselves. We bring them in these meetings. They will be bored the first few hours, but later on realize that we are talking sense. Thank you.
Sorry, Bethany. Just at the risk of being controversial, I think the reality is that unless we get greater diversity at all of the levels of decision making, then we're not going to get policy engaging in the way that we should. So, if Zika virus or rabies, two examples, if they were taking out middle-aged men, seriously, we would have policies in place pretty quickly. But that's not the case at the moment. And I make that very seriously. I think we've got to think about who it is that's impacting upon and who is then ultimately making the decision.
And so to that end, I'll put my association and not the accreditation hat on. So AVMA has several fellowships available for veterinarians and externships for students. We're headquartered in Illinois, but we have a Washington, D.C. office. And it's a student externship spending about a month in the Washington, D.C. office and learning about policy and learning about lobbying and learning about how the federal government works or doesn't, whatever your viewpoint is. And it's very, very well received. And then the fellowship program, you were a congressional fellow, is for veterinarians to come and do a year-long, and I'm sure other associations do this too, a year-long working in a congressional office on an issue or several issues, oftentimes of animal health or public health importance. And that really has, I think, grown a cadre of veterinarians who really truly understand policy and who find it incredibly interesting as well. And I think the more we can do that across disciplines of the healthcare, the better off we'll be at impacting policy. Unfortunately, it's not going to happen overnight, but it is there, and I think that needs to be promoted. One of our veterinary schools has a public and corporate track which really focuses on public policy. And so I think those kind of programs will help in the long run.
So good question. We are within about 2 minutes of the end of our time, and so I hope that the discussion has, if you hadn't been thinking about it before, that you might be thinking about now the pros and cons of globalization, of accreditation, or quality of professional endeavor, and how One Health and we didn't really talk about interprofessional education and how it relates to One Health, but I think it's a fairly obvious connection. And so I hope we've given you food for thought on that. Any last questions or thoughts? How many of you had thought about One Health before you came to this session today? A few? Okay, quite a few, yeah. Well, then I will just close by once again saying a very sincere thank you to the panelists. You did a fine job, and I really appreciate that you were here. Thank you.